Hello and welcome to iTalks, brought to you by iCAD. iCAD is a platform dedicated to expanding knowledge, exchanging ideas, and advancing well-being in the addiction and mental health industry. iTalks brings you courageous conversations presented by Sam Quinlan, Sophia Capria, Minta Johnson, and today's host, Christoph Sauerwein.
Welcome, all of you, to the iCAD 2020 series of interview. Today, I have the great pleasure to host Heather Hayes on our iCAD channels. A very, very warm welcome to you, Heather.
Christoph, thank you so much. It's really an honor and a privilege to be a part of the iCAD conference, and I'm excited to talk today.
The title of your presentation will be Theoretical Framework for Working with Women, an Essential Resource for Women Case Management. So before we get into the depths of that central theme, allow me please, Heather, just to introduce you in a few words to our audience here. I probably need a piece of paper because you've done so much, so please forgive me. You're the founder and the CEO of Heather Hayes and Associates. You are a very famous international clinical interventionist with significant academic and training background. You're also renowned international speaker and author. You're known as one of the US most preeminent authorities of these topics. Many people see and praise you as a veteran. I'm sorry to put it that way, but I think that's really true, of the behavioral health field. 30 years of experience working with addiction, but not only addiction, working with trauma, mental disorders, adolescent, young adults, complex mental health issues, and obviously the full spectrum of addictive behaviors. You also serve as an on-air expert and consultant for CNN, Dr. Oz, and you've been featured on many American channels in broadcast, ABC, CBS, Fox, MTC. But most importantly, outside of that, it always intrigued me. You're also a hostage negotiator, and you trained with the FBI, and you've been serving as a volunteer amongst your communities, trying to resolve very drastic situations, which I think is important to keep in mind. You're just more than just an interventionist. You care about people and drastic situations. So I think I'd like to ask you a question. We've known each other for years, and I never asked you the question, actually. You trained master in psychology, you trained in Erickson therapies, many other things, and you decided to become an interventionist. And I think I dare today to ask you this question that was always in the back of my mind. Why did you become an interventionist?
That's a great question. You know, I came into the field sort of through the back door. So most of my addiction was that of an adolescent, young adult. So at 21 years old, I went into treatment. But before that, I decided that maybe if I studied psychology, it would help me quit drinking so much and doing so much cocaine. Can't say that the change of major actually, helped me get into recovery right away, but I think it was part of my journey. So after I got sober, went through treatment, I decided to keep studying psychology. And I had this passion for helping particularly young adults, adolescents, because I think there was so much of a mirror image there for me. So for years, I got my master's degree. I graduated from my master's program in 1986. I got it up in the New England part of the country, came back to Atlanta, and I helped open up an adolescent unit. I worked on the unit and started private practice work. And that's where a lot of, I think, my better training began. I got trained in eating disorders, trauma, Ericksonian therapy, the work of Jay Haley and Chloe Madonis, the work of Salvador Minuchin, family systems therapy. So for years, I had a private practice where I only did a handful of interventions on the side and mainly did private practice work. I had about 50 clients a week, did a lot of group work. I was trained in a lot of experiential therapies. And then probably around 2000, I think I just started to get a little stagnant. I wanted a little bit more. I was, tried some different trainings. I got trained in equine therapy because I'm an equestrian and have horses. I got trained in a couple other modalities. And I sort of had presented in front of me a couple of my colleagues that said, hey, will you come help me do this intervention because of my clinical background? And I loved it. I loved the front end intensity. I loved the problem solving that goes with it. I loved the ability to come in and really try and sort out, how do we help someone come in and engage them in treatment when they don't want to get help? And how do we do that in a way that's respectful and that really decreases any kind of trauma that can happen from that? When I was initially trained in intervention, the model was one where you came in with sort of a list of everything the person had done wrong. And you presented it to them and you talked about, you could say, I feel sad. You weren't allowed to say mad. It was always done as a surprise. And I quite frankly didn't really like doing it. So as I became more exposed to models of intervention that were maybe more by invitation, were more loving and not that dirty laundry list, I really felt a calling to go out and do more intervention work, particularly around women. So as a woman who's in recovery, who has clinical degrees and worked with a lot of women and young girls, I was trained for play therapy. So my clinical practice, I worked from age 4 to about 80. So I really felt a calling to come in and help do the intervention process in a way where we didn't add on to the shame.
I think what you said is central here. We have discussed that in the past, Heather, and I think it's important to make our audience aware of all that. Intervention is not actually a simple act. It involves most often a lot of trauma, a lot of re-traumatization. It's actually the place, I think, in our field where we need to have the most integrative and eclectic skills to be able to cope, because it's like exploring a minefield.
You're right. It really is. And when you go into an intervention, you're working with an entire family system. So you're not only responsible for the person who you want to get the most relief from initially. So if you look at it like you're triaging things, the person most in crisis, but you're also responsible for the entire family system. So often you have others there who have experienced trauma themselves. And when we think of trauma, we often think of trauma, child abuse, natural disasters, war, domestic violence. But I also think there's another level of trauma that people who are addicted go through, and that's the way we traumatize ourselves when using. So if a 20-year-old young woman is addicted to heroin and doesn't have any money, and the only way she's able to get her drugs is to sexually act out to have sex with her drug dealers, we don't necessarily come in and say she's been raped, but it's very traumatic and it's gone against her morals. And she's done things that as she gets sober, as she gets into recovery, she's done things that she will begin to see the layers peel away. The trauma from that will affect her. She will actually get to a place often where the memories can be intrusive. You can have flashbacks. And I think even that is something that people, not just women, men as well, can experience. And it is very traumatic. So even if some don't have childhood, adverse experiences, they may have gone through the traumatization of themselves.
What you said here is we cannot dissociate addressing mental health issues and addiction, obviously, from the trauma issue, first thing. And second thing, I kind of sense now that we're getting into the woman's specificity, or the specificity about women in that respect. You just gave a very dramatic example, and you're right. So let me to kick off with the woman aspect of what we're discussing right now. I'm going to read something that you wrote, if you don't mind.
Okay.
When you're going, oh my God, what it is. Women face unique challenges regarding their physical and mental health that must be recognized and explored by mental health professionals. Such challenges include women's exposure to violence, culturally supported roles for women in traditional settings, and mental health concerns across the life cycle. Women are unlikely to seek treatment for fear of losing their children. They're also unfulfilled by the modern day's models of development which advocate individualism and independence. Women thrive through connection. Therefore, the way we need to help women recover needs to be through a connective model. Do you still agree with that? I think
I still agree with that. You know, the majority of the research that first came around on how to help treat was done by Dr. Jelinek. Dr. Jelinek changed the way the field looked at addiction by coming in and saying, here are the signs and symptoms, here's how it progresses, and here's how we recover. He did that study with around 200 men. There were no women involved in that study. And so with that, the way that we come in and we treat women is a male model. Women traditionally and historically have had a much more difficult time seeking treatment. The research shows that the numbers are not any different. There was a time where we believed there must be more male people with substance use disorder than females because so many more ended up in rehab. We now know that that's not true. The numbers are the same. Some studies even show women a little bit higher. But women face a lot of different issues, particularly childcare, and the fear that if I speak out about my addiction or someone recognizes it, I may lose my children. That's a big obstacle for women being able to go and get help. The other thing is that women do recover and get better through connection. There was a lot of work that was done starting in the 80s at the Stone Center in Wellesley, where the feminist theorists came together and came up with a lot of studies that showed that women need connection, women thrive in connection. And yet the way that we do treatment is that we have someone come in and we have them completely disconnect from their children, from their outside world. Some facilities that might be a few days, for some facilities that might be a week. In some facilities, it was throughout the majority of their treatment that you weren't allowed to use the telephone. And this is a model that just doesn't work for women. This is a model that comes in and says detox from all those things out there. But women thrive through relationship, through connection, and where they get in trouble is when there are obstacles that come in the way of that connection. And that can be mental health issues. That can be relational issues. That can be trauma, things that get in the way of the connection. So we really have to look at, from the beginning, how we work with women. And part of that is looking at the historical piece of it. You know, there's a lot of data, there's a lot of evidence from the beginning that when women became addicted, there was a whole temperance movement here in the United States that portrayed women as you were either a harlot or needed a man to come in and rescue you, or, you know, that's what women addiction looks like. You can think about how back when I was growing up in the 60s and 70s, if a man got drunk, he would kind of get an attaboy. If a woman got drunk, she was called a lush or or she was slutty, or, you know, again, that is very stereotypical, and we've come light years from there. But it's part of the history that's gotten us to where we're at today. And so I think all of those issues, you know, the historical piece of how we got to where we've gotten to, and then how do we continue to move forward? Stephanie Covington did an amazing job coming in and saying that Jelinek curve just doesn't fit for us. The Jelinek curve actually kind of goes down and up. And Stephanie Covington came in and said it really is more like a helix. You know, it's much more involved. It's not such a linear process.
There's something I absolutely, in my experience, I'm 160%, 1,000% relate to what you just said. Even though we have advanced in a society, you know, fast forward, not seeing women as they are, there's an element of collective subconscious about women. And in 67% in England, 67% of women seeking or in treatment, seeking for treatment, report adult or child sexual abuse. So I cannot help putting my foot into the shoe of a woman that being exposed in group therapy to men who are wherever they are, have an element of re-traumatization. Doesn't feel safe.
No, it doesn't feel safe. And I heard Claudia Black talk years ago. I need to ask her where this stat came from. But what she basically said was that there was a study that showed that men do better in mixed gender groups and women do better in women's groups. So it's another example of a setup where the men are sort of taken care of or do better because the women are there and the women don't. So it's almost at their expense.
Well, we're going back to very profound male and female interconnections here. I'm not surprised. I think, well, I don't know where Claudia picked that up from. You're right, but I absolutely see that with group of patients all the time. So then the idea here that we should create a feminine world, not a woman's group, a feminine world where the femininity could express and be looked after inside the treatment modality. Because there's something important I want to share here. For years and years, we conceptualize some mental health disorders as woman hysteria. So thank you to Sigmund. Now this is a typical woman's mental health issues. Now, what we say here, I think, is important is that there is no gender specificity into the disease, the disorder, the mental health issue. There is a differentiated way to experience it, to respond to it as a mental disorder. So the way to respond to the mental disorder by a suffering patient is going to be feminine or masculine, but then the way we help has to be differentiated from one gender to the other. That's important.
Yes, I think that's very important. And I think from the beginning, it's not just in our field. I mean, women who go in and talk to their physicians about feeling depressed or feeling anxious are much more likely to be given a prescription medication than a man is. And they're much more likely to be given medications than to end up into formal care. So that's, a wider issue. I think that we are growing leaps and bounds in the mental health field and the addiction field at looking at gender issues and looking at gender fluidity, how all of those issues have to be addressed and we have to be sensitive to them. But I think that there's another place where learning needs to happen, and that's in the bigger, with our physicians, with our, particularly our primary care doctors and our OBGYNs. Women are more likely to get prescribed antidepressants by their gynecologists than any other healthcare provider. And second would be their primary care physician. So they're not getting those resources either where they can go and have the therapy, have the connection, and look at the underlying issues.
Some people argue that gender-specific approach to mental health and treatment is productive, but on the other hand, mixed gender helps also one gender to face the other gender and to start to learn how to interact. So there might be probably a dual process here, which is we need this intimacy in this feminine world to help women to internally heal, but then they have to redeploy their skill sets learned in treatment to interact with the other 50% of the human race called the men.
Well, I think it's both and. And I think a lot of it, there's some women who do very well in a mixed gender group. They're, mixed gender treatment that maybe has a couple of gender specific groups. There are others, because of that historical piece, could be trauma where they need a more gender specific program before integrating back into, that next step after primary care, where a lot of it is looking at integrating back into the community, back into life, and having the structure around to help someone do that. So you don't just go from inpatient back into the, back into the world without any support and a place to process that. But I think what's important is how female clients are addressed within whichever context they're in. Are we helping them to become more empowered? Are we looking at issues that are important, like a mother of a 3-year-old needs that ability to be able to Zoom or Skype or FaceTime with their child in the evening for a few minutes, and the child needs that too. How are we talking about and framing relationships for them? There's a way in which we come in and tend to pathologize people and say, oh, you're enabling, or you're codependent, or you have all these dysfunctional relationships. You need to stop that. Well, it's not black or white. And I think part of it is coming in and help people learn the importance of connection, the importance of attachment, where the beginnings of that even starts. And then how do we help women in particular to move into healthier relationships where they're more empowered, they feel comfortable using their voice, they're able to ask for their needs and work on that through a collaborative team that helps support them and their families, and maybe ways in which the relationships will shift. I think about from the bigger perspective, like when we think about family systems and we think about how systems come to us or present to us when we're in treatment, they come and like you have the family members and they're, you've got this way in which they're organized that's not beneficial, it's not helpful. And there's a part of what happens with good treatment where you have to deconstruct the way the family relates so that they can reconstruct in a way that's healthier, more beneficial. And in that deconstruction phase, it can be disorienting. It can be scary. There's a fight, a push, an internal drive to go back and connect in that way. Anxieties kick up. And so I think part of what our job is too is to help families and women within families, mothers who have children who are addicted, to learn the importance that we're not saying don't connect. We're saying let's look at healthier ways to connect. Does that make sense?
It makes absolute sense. And something came to my mind listening to you, Heather, that one of the characteristics maybe of the femininity of a human being is the connectivity. And it's almost a characteristic that is more salient with females than males. And I'm using female and male because I'm speaking biology probably almost here. It's part of their purpose in giving birth, nurturing, education, upgrowing, and perpetuating the surviving of the species, actually. So this is the idea just came to my mind listening to you. As if we cut this propensity to connect in a woman for the sake of mental health treatment, it's almost like a biological amputation. Now we disable an innate capacity of a woman instead of trying to heal it and try to make sense of that and restore it to a form of sanity, because we use words like you enabling your children, or you damaging your children because you're having this line of cocaine or you're this bottle of vodka, whatever. Now, we disrespect the profound nature of the femininity of that human being when we do that.
Well, I think we disrespect the importance of the relational connection too. That whole, in cultural relational therapy, they talk about when people are able to connect, when they're able to connect in healthy ways, it helps fill their lives and it helps them to flourish, they even talk about what they call the 5 good things. And one of the 5 good things is zest. And when you have zest, it's like that energy in your life, that passion, it helps to give more meaning. So I think that we can slow those things down. I also think that people are resilient, women are resilient. And so there are a lot of women, myself included, that went through traditional treatment and somehow, some way were able to sort through and work out and find those connections. I mean, when I look back on my earlier years in recovery, again, woman and a young adult, so 2 issues there. For me, some of the things that stand out as being the most important are the relationships that I had. The relationships that I had with my physician who was patient with me when I was in rehab, when I was arguing and fighting about how I was way too young to have to stop using drugs. My relationship with my therapist that I had who helped me get into treatment. The relationship with the people in 12-step that helped me to know that I could have a good life, that I could flourish. The relationship with, so again, I think that we come around, many of us. But if we could take out that piece where you have to fight, and maybe others who are really turned off by the lack of, again, being told you can go to treatment, but you can't talk to your children for X amount of time, or the parents who come in and say, I'm the worst mother ever because I'm enabling my child, and then you ask them to kick their kids out and they're not ready to do that. And again, I think there are ways that sometimes we cause more harm than good. And then looking at, for me, when relational therapy was presented to me, when I began to learn even about object relations therapy in graduate school, things started to make more sense. And I thought, oh, this is such an important piece that we don't necessarily get in treatment or just through, 12-step recovery that can really make a difference. So I think it's also on us to come in and say, for women, here are things that are different. Here's a different way for us to approach this with you. I mean, down to even looking at hormones and what women go through hormonally monthly. Or one of the trends that I've noticed over the years as an interventionist is that often women will be pretty successful. I don't know if you want to call it functional drinking, or functional use, but it looks different. And then all of a sudden they hit their 40s, perimenopause comes into play, and suddenly things spiral out of control and they get in trouble. There's some different times we see women get in trouble. Puberty, our 13, 14-year-olds get in trouble. Young adulthood, we often see a spike in admissions to treatment. And then again, I often see women in their 40s or then, that retirement age. And of course, everything in between. But I think part of that is our responsibility when working with women as part of our history and physicals to step in and say, let's do some hormone testing and see, how you're feeling. Because when you take the drugs and alcohol away, it's our responsibility as providers to step in and say, how can we help you feel better, get the coping skills you need, enjoy life, and cut back on any issue that may come in and contribute to a relapse, help treat the trauma, help give you some tools to deal with that, help with your body image, help with eating issues or your relationship with food.
You summed it all when you said a woman or a human being born a female becoming a woman has to go to major traumatic transformative events in their life. Puberty is, I'm speaking from a male position right now, Heather, I cannot imagine the massive body and mind transformation that means puberty for a woman, a girl,
Right.
a woman. Because I just had to grow a little bit, a few genitals organ and a bit of muscles and trying to become cocky. That's the job as a male. As a woman, the bone is changing, the hormones are changing. There's the monthly bleeding. I mean, there's a lot of sacrifice here. You have to sacrifice, a woman have to sacrifice part of their body, as in being penetrated. I mean, it's a biological amputation or abuse, and it's not abusive necessarily in the act, but there is an element of physical transformation, as in part is lost. And then comes the womanhood, and then pregnancy, 9 months, carrying a human being, it's heavy, it's exhausting, hormones are challenged again. And then comes the end of it, which is the menopause that you tapped onto, which is, I'm afraid, completely overlooked at the moment as a mental issue. I'm not calling it a disorder because it's nature, but it's
Right.
a serious mental issue. And on top of that, women at the moment in the Western world, within our civilization, I think they ask to become men at work and to disguise themselves into senior executives or whatever, or blue collar, white collar, it doesn't make any difference here. They have to play it as a man at some point. In the middle of all that, the intimacy with yourself, with your peers you need to recover for whatever mental health requires to become again a woman, to acknowledge and authentify all that.
Well, and I think all of those issues are so important. I mean, I'm really glad that you listed them. And then I'd also add women who are trying to get pregnant and unable, or women who have miscarriages, which are excruciatingly painful, and yet society doesn't give us. There's not a ceremony, there's not a funeral, there's not a place to grieve that. Women who are coming out as lesbian or are trans women, where do they get that support? And we talk about, not just needing to support the woman, for example, coming out lesbian, but then there's also this whole process of coming to that the families go through as well, where they also need to go through their emotions and how it affects them, and that the things that they had once, even the most supportive parents are working on understanding and moving through that what they had expected is going to look a little different. And, how do we support all of that?
So as an interventionist here, Heather, you're on the front line of detecting and trying to make sense and assess that in a family system or with a specific patient or subject within the family, the loved one in need. Now, applying all what you said, which I believe you do, obviously, and then you assess all that and you hand it over to people who are going to look after the subject, one in pain, or maybe intervene as family therapists, and you hand it over. I'm going to ask you a controversial question. Do they get it?
Some do. Some are still on that learning curve. And then there's some places where I think things happen that maybe cause more hurt than help. But I do think that we're better. There was a time back in the 2000s where there was a conference that was one of the first conferences that was ever done on intervention. And I didn't speak at it, and I didn't attend it. And one of the founders of that conference asked me, why didn't you come? And I said, I couldn't support it because you did a conference on intervention and you had a lot of different speakers and you didn't have one workshop on women's issues. Now, there were also other important topics that were not included either. So the next year, I spoke with two of my colleagues, Joyce Sundin and Francesca McCarter, and we spoke on women's issues. So sometimes things just get missed, and it's not like someone's trying to shut someone out, but sometimes you just have to say, hey, look over here, what about this issue? I think what's important is that we all come into the work that we do not coming in with that critical, correcting, somebody's doing it wrong piece. Like, I like to come in believing that everybody's trying to do the best they can, and sometimes we miss things. I miss things. I need people to tell me every day, hey, you forgot about this, or what about this issue? So I think what's important is that we continue to look out and say, how do we make sure that the vulnerable clients and families that we work for do get their needs met? And how do we continue to evolve? We do things much differently today than we did when I first had my first job in the field in 1983. Much different. We're much more trauma responsive. We take a lot of different issues into account. We have a much more respectful approach than that let's tear the addict down and build them back up approach that we had, that I think was so hurtful, or ignoring the families and saying, you're the part of the problem, or referring to families as sick. So I think that our attitude about that is really what helps. But I also think, like, from where I come from too, part of what my team does, we work hard to make treatment that, intervention's a process, treatment's a process. So I don't just go in and get someone help and hand them over to the treatment center. I mean, I do hand them over to the treatment center, but we continue to work with the families and continue to be involved. So when the person comes out, we're making sure that issues continue to be addressed, that the women become more and more empowered, that we help them to find experiences that help them to feel better about themselves, where they can find connection and healing through that.
That's a message of hope, Heather. And unfortunately, in the UK, we are not equipped enough with women-specific treatment or mental health help, let's put it at large. And so I think it's time just to reconceptualize, pose, and go, okay, now this is what we know, and this is what we need to develop and progress on.
Thank you.
Thank you so much, Heather.
Make sure to visit our website, www.icad.com. Tune in on Tuesday for our next episode. We'll see you then for more great, thought-provoking, courageous conversations.